do it again and again, then complicated things become simple. You understand? Huh? It's very, very important. Okay, what I told you just now. So, what we'll do now is antibiotics. Okay, so I've done this in the past, but I've done it in a different way. I'll just show you this. This is a very different one. Okay. So, at the moment, we are actually saying there are difficult to treat resistance. This is a new terminology that has come by the WHO. Difficult to treat resistance. Okay, difficult to treat resistance, and of which we normally talk about these kind of resistance. Okay, that is extended spectrum beta lactamase, Enterobacteriaceae. AMC, that is AAPC, Enterobacteriaceae. We have carbapenem resistant Enterobacteriaceae. When I say Enterobacteriaceae, what does it mean? No, when I say Enterobacteriaceae, it means only E. coli and Klebsiella. Then we have another category called as non-fermenters. The other category of non-fermenters are Pseudomonas and Acinetobacter. Clear on this? Simple. Okay, when I say CRE, Enterobacteriales, I am actually talking about Klebsiella and E. coli. So whenever you see CRE, you cannot say CRE to everything. CRE is only for Klebsiella pneumoniae and E. coli. Okay. Hello. You cannot call CRE to be everything. You understand? CRE is not everything. You cannot just say carbapenem resistant CRE. Okay? It's not like that. CRE, the term E, is for Enterobacteriaceae. Okay. Whereas CRO, you can call CRO everything. Carbapenem resistant organism. CRO. You can call it CRO. Alright. Clear on this? And when you say Pseudomonas, we actually say difficult to treat resistant Pseudomonas. Or you can call it as carbapenem resistant Pseudomonas aeruginosa, CRPA. Or when it's Acinetobacter, you call it as CRAB, carbapenem resistant Acinetobacter baumannii. So these are the terminologies you must remember. Okay, when these terminologies will come again and again in books, in chapters, when doctors are talking, when seniors are speaking, you will hear these terminologies. You must understand what we are meaning. When we say MDR, it means there is resistance in 3 classes. More than 2 classes, basically. Resistance in more than 2 classes. You understand? So it's resistant to quinolone and beta-lactam. It becomes multi-drug resistant. Okay. When it is XDR, it means all but 2 are resistant. All but 2 are resistant. Everything is resistant, but it's only TK and colistin sensitive. Clear on this? Or that's XDR. And what is PDR? Everything is resistant. So understood the terminology? MDR, XDR and PDR. Clear on this? Anyone till now? Any problem till now?
So say it comes like only sometimes usually colistin is intermediately sensitive.
That means sensitive to hai na?
That
So
will come in XDR.
XDR. Okay. And the only organism last time we discussed which does not require to follow the MDR pattern is MRSA. That is the only one that does not require, because it is resistant only to methicillin, and still we call it as MDR. MDR we said needs one antibody in 3 classes, more than 2 classes, right? So MRSA is the only one that does not follow the usual pattern. Okay, you can stop me anytime if you find there is a mistake or you are not understanding. Stop me, because it's very essential that you understand these things, because bar we cannot keep. I taught this to you in another PowerPoint. This is just the start of my one PPT. Okay, resistance. When you talk about resistance are of various mechanisms. So what you hear as CRE and all is carbapenemase producing organisms. That means the particular organism produces an enzyme that inactivates the antibiotic. So if you have a beta lactamase, it is producing a beta lactamase, which may be a cephalosporinase, maybe a penicillinase, it may be any of those, which is going ahead and inhibiting the destroying the antibiotic. Clear? The organism is producing it. Clear on this? This is carbapenemase. This we call carbapenemase. You heard this carbapenemase. So when you do a carba R, you are only looking at those enzymes that are produced by that particular bacteria, which will inactivate certain antibiotics. So you heard NDM, you heard OXA48, you hear all the CTX, you heard all these are the enzymes. There are multiple enzymes. Okay, multiple category of enzymes, but we are looking only at those 5 which are seen in carba R. VIM, IMP, NDM, OXA48, KPC. This is all that is seen in your carba R. Clear on this? Clear till now? Clear till now? This carba R, when you do these enzymes, these enzymes are further you can actually classify them as, you heard ESBL, right? ESBL means extended spectrum beta lactamase. Okay, so this per se is divided into an Ambler class. The Ambler class are of 3 varieties. Okay, so you have A, class A. Now in class A, the enzymes, these enzymes that are talking about, this enzyme related resistance, Ambler class mein divide ho jate hain. So you have A, you have C, and you have D. This is one part of the enzymes. This is called as serine. These are called as serine enzymes. These are called as serine enzymes. In the A part, you have enzymes like KPC. We just now talked about KPC. KPC comes here. Class A. TEM. This is discovered, one of the first enzymes that were discovered from a nurse by the name of Temorina. Okay, TEM. Then you have SHV. So you have loads of enzymes, of which these are the categorically named everywhere: TEM, SHV, and KPC. This class C is a completely different class called as AMPC. AMPC. It's called as AMPC. AMPC. That's why you remember it as C. Okay. The D is a completely different type called as OXA group. An OXA group is up to 140. What we are testing is OXA 48. There are so many OXAs, there's 20, 23, so many are there. The commonest in India is also 48 and 20 also. 20 is there in Pseudomonas. Alright. So there are maybe 140 of these. Even as we are talking, maybe more are getting discovered. You understand? So what we are testing in our exams, in our Carba R, is only KPC, then OXA, and where is NDM gone?
B.
So the B is missing here. So the B comes here with another group called as metallo group, where B comes, and this is called as metallo beta lactamase. Metallo beta lactamase, where B is the NDM. VIM, Verona integrated molecule, IMP. These all will come here. These are NDMs, metallo beta lactamases, characterized by the presence of a metallic ring, chelated by zinc. Okay, so you have, so this is how the classification is. So tomorrow, why is it important for you to understand this? Because of the fact that in the Indian scenario, you have the maximum amount of metallo beta lactamases. Our basic 4 organisms that cause problems in our ICUs are Klebsiella, Pseudomonas, Acinetobacter, and E. coli. Okay, Klebsiella is known to have a very large amount of combination of enzymes. So one bacteria can have 2 enzymes. You've seen that very often. You've seen that. They can have the combination of OXA 48 with NDM, which is very common in the country. You know, Klebsiellas, 50% of them will have a combination of NDM and OXA 48. E. coli, maximum of NDM. You understand? Pseudomonas can also have any of these enzymes. So this is one of the ways that resistance is created. One of the ways. Okay, that means there is a gene that is causing this problem. There is an enzyme that is making this enzyme in that bacteria which is causing the resistance pattern. Clear? And when we say BLBLI, what we are doing is this. We are trying to inhibit this enzyme somehow. By inhibiting this enzyme, we are trying to go ahead against the resistance mechanism. So there's only one antibiotic that works against all of these. That's against AMC is cefepime. Okay, that you must remember. Okay, the rest nothing. Normal cephalosporins can work. Okay, clear till now? Now this is one part of resistance, but there is also chromosomal resistance. Matlab, I am getting resistance because I have something that will inactivate the or prevent, or I will become stronger myself. And so what does it do? It kind of mutates. It kind of gets a new chromosome, and that chromosome, how does an antibiotic usually work? You have a cell wall of the organism. The antibiotic will come and get attached to a protein called as penicillin binding protein, and then, or it will have a pump over here. We'll get into from that side. What these things do, or a channel called as a porin channel. Okay, so they will mutate. They will mutate. These organisms will mutate. When they mutate, they either switch off this thing, or they mutate to form such an antibiotic अंदर क्या तो भी मैं उसको बाहर फेंक दूंगा by efflux pumps, or I will alter this protein binding site and prevent the antibiotic from getting stuck over here. PBT23 mutation it's called. Okay, E. coli is known to have a lot of PB2 mutations. Pseudomonas is known to have. So you got the point. So this is called as chromosomal. This is chromosomal. It doesn't need to form an enzyme at all. It doesn't need to form an enzyme. It just will have these efflux pumps. It will have these changes in foreign channels. It will have this alteration of penicillin binding proteins, which will actually prevent even the entry of the organism. So entry of the antibacterial and antibiotic. Clear? So you have chromosomal resistance mechanism and you have this gene resistance mechanism or enzymatic. Okay. So now you must understand by now that by just doing a Karba R, I can't figure out whether the patient is sensitive or not sensitive. It will only give me an idea because these mechanisms are not found in any way. You cannot do the test for this. And for the test of this, you need to do the normal Vitek, where it is phenotypic method. That is called as phenotypic method, where you put a disc and you see clearance. That is called as phenotypic method. When you do disc dilution, broad dilution is called phenotypic methods. That is genotypic methods. These methods are called as genotypic methods. Whereas the method in which you put a disc and you find out everything that's a problem, that's called as phenotypic methods. Clear? Jairam, stop me if you want to, anything you want to add on to. Okay? Clear? Any doubts still now?
Even in Karbar we are included only 5 enzymes.
So there also there is a problem. You understand? So there are so many enzymes. There is GES, there is so much enzymes. Maybe thousands of enzymes. Even we are only finding out those 5. That is why this is not the gold standard. That is why Karbar is not the gold standard. The gold standard remains phenotypic methods. The gold standard remains a culture showing sensitivity. That is the gold standard. That is the gold standard. Clear on this? Clear? Huh? Clear? That's why we need the cultures quickly. This gene will only give me an idea. Okay, maybe this antibiotic will work. That's all that it does. Clear? So when I say this CRE, carbapenem resistant enterobacteriaceae, I am actually talking about these things. Okay, when I am talking about these things, I am looking at it being plasmid based. Basically, what does it mean plasmid based? They are kind of jumping genes. आज मेरे पास समझ लो 2 bacteria है. There is one E. coli or there are 2 E. coli. One E. coli has got this carbapenemis and the other E. coli does not have it. This plasmid will just move as a horizontal gene transfer from here to here and even this will become resistant. It's just a gene transfer that like that. Plasmids are supposed to be ones that actually jump from place to place. And since they jump from place to place, you will end up getting resistant colonies. Clear? Clear to this? So most of the CREs are actually plasmid mediated. So this, what does it explain to you? Even if you have one, the whole population is going to be resistant. Clear? So CRE means carbapenemase enzyme. Now you understood what is CRE? Any doubts? Any doubts? Okay. Carbapenemase enzyme. Okay, but it also, so let's take the example of this female. Okay, this is Diana. She's a 13. Did I do this PowerPoint? I have not done it. I think one of the first 4 slides. I have not done. Not done. Okay, then good. See, the first 4 slides would have been the same from the earlier. Yeah. So you have a 39-year-old lady, pyelonephritis with cellulitis. Very common patient. Patient who comes into you with diabetes, with hypertension, pyelonephritis, cellulitis, and now the patient is in front of you. He is in a pulse rate of 150 and a BP of around 90 systolic. How do you actually choose your antibiotic? You will choose your antibiotics on a number of things, which include severity, which includes patient factors, which includes previous what the patient has received, and what is the local microbiology. So there are many reasons how you select a antibiotic. Okay. Now he received a standard dose of meropenem. This is the standard dose. If you look at the package insert of meropenem, the standard dose is 500 milligrams 3 times a day. This is what the standard dose is. Okay, and a tigecycline of 50 milligrams twice a day. Right? Is this okay? It's a standard dose. I mean the standard dose. First of all, what you must remember is the standard dose is always based on healthy population. It's not on a population that is sick. Whenever there is a standard dose, it is completely based on a healthy population. That's how they create doses. Okay. When a person is sick, critically ill, there are multiple other problems that are occurring. Can anyone tell me what are the multiple problems that are occurring?
Cellular function will be.
But that will not change anything for me. What will happen
Also
in critically ill patient?
Suppose in critical ill patient, septic patient, there will be decrease in the protein binding, increase in the volume of.
So what will happen is there will be some problem with protein binding. You're right on that. Means proteins may go down, go up because protein is an acute phase reactant. it may go down, go up. And what is that implication for you? The implication is this.
Drug dosage will be changed.
Volume of distribution.
Volume
No,
of distribution.
no. What will happen with protein binding? It is only the free fraction. It is only the free fraction of the drug that actually works. It is only the free fraction. So if I have a very badly protein bound drug, very hard protein bound drug, and I have a patient in severe sepsis, and I give that particular drug, it will not work, no? It will work less. And the classical example of that is ertapenem. The classical example of that is ertapenem. That's why we don't use ertapenem directly here. We may use it as a step down, but we'll never use it as a direct drug. Why? Because ertapenem is markedly protein bound. So what will happen? I give ertapenem. Ertapenem will get bound to the proteins. It get bound to the proteins, and the free drug that is available is so less that it will not act at all. It is so less the action will not be effective. Clear on that? Clear? Protein binding? Clear on this? But then why is this drug there in the first place? Well, protein binding, what it does, it creates like a sink, you know. It will remain in the body for a long period of time and slowly release. So what does that do? It reduces your dosage frequency. You give it once, that's enough. I mean, धीरे वो बाहर निकलता रहेगा. So it has got its effects and its other effects also. You must know where to use it. That is why when I'm thinking of which drug to use, I'm looking at protein binding. Are you understanding? So if I have a patient who's very sick like this lady, I put him on meropenem, and now it's 6 days, 5 days, now she's pretty stable. She's BP has become, pulse has become okay, everything is fine, and I have sensitivity, phenotypic sensitivity. By that time ertapenem is sensitive. 4 days, I can convert to ertapenem. You understand? Hemodynamically she is stable, there's no requirement of keeping meropenem. Another 2 days more I give ertapenem, and once a day I can send her home. You know, I can just tell her, take one injection of ertapenem, that's enough. Simple.
So we are converting that dose just to reduce the frequency.
Reduce the frequency. That is how you may want to use it. I'm not saying you have to use it like that, but you may want to use it like that. That's somebody use it. You understand? But I will not use ertapenem upfront. Irrespective if the pharma company sends me to Japan 10 times and Greece 2 times also, I will still not do it because it's wrong to do it. It's completely wrong to do it. Are you understanding? Ertapenem. Clear? Protein binding. Then what? So we'll come to all that now. So to understand what happens to an antibiotic and how to decide an antibiotic, you really need to understand a few parameters. There are a few parameters that you need to understand. If you think that this is the best that we could do for NO to survive, you will probably at the end of the lecture you will say probably no. And I'll tell you how it will come to that. Okay. That is why you need to utilize knowledge of PKPD. You need to utilize the knowledge of PKPD, which will help you improve the chances of renal survival. PKPD. You've heard of this word PKPD, right? And that's the background of any antibiotic you have. Any antibiotic that you have, the background of that would be PKPD, pharmacokinetics and pharmacodynamics. Okay. Now let's go and understand what that is all about. Judicious use of antibiotics. This is actually the PKPD approach. All right. So there are multiple. If you look at articles in literature, no, you will get so many articles that you will be tired of looking at PKPD. In fact, when you put PKPD on PubMed, see the number of hits that you are getting. So 3,59,308. So it becomes very difficult. It becomes very difficult if you have to read so many. You cannot read on your entire life. Even your son will not be able to finish this that much. So at the end of the day, you require to make it simple. And that's why I always have to be critical. It has to be made simple. Okay. So 3-5 results. So what is PKPD? So now this is the entire background of antibiotics. Okay. So what you have to understand is something called as exposure curve. Now on the exposure curve, what you're seeing, you're actually seeing that there is concentration on one side and time on the other hand. Okay. This is taking me properly from here. So exposure on one side, and because I have to send this to somebody wants it. Exposure, concentration on one side and time on the other side. So what is pharmacokinetics and pharmacodynamics? What the drug does to the body is pharmacodynamic. That means the effect is pharmacodynamics. Pharmacokinetics is what is happening inside the body. What you see here is what is happening inside the body. This is pharmacokinetics. What is happening? You have given the drug has reached a certain amount and then it has started coming down. This is what it is saying. This is pharmacokinetic. So with this equation, can I understand how much to dose or not? I will have an idea, but still I will not know because I don't have the effect in place. I only have what has happened to the drug? What has happened to the drug, right? What am I seeing? I'll just put this curve again for you. So let me put this curve again for you. So you have a curve that says pharmacokinetics, which basically puts concentration on one part of the equation and time. That means as you're giving the drug goes up and then comes down in the body. But the effect of the drug will be very, very different from the start to the end. That is not equated here. Okay, so if I draw an effect, let me draw an effect. I'm drawing an effect. Classically, effects will reduce over a period of time, classically. So I'm now putting an effect. I'm putting an effect. Now let me put the MIC. What is the MIC? The minimum inhibitory concentration which inhibits growth of organism. Okay. So let me tell you that you have an MIC that's over here. Say for example. Alright. The concentration here of this antibiotic is 90. The concentration over here is 40. Let me assume it is 40. Or let me assume this is 150 for the sake of symmetry, and this becomes 40. And the MIC is actually 20. MIC is actually 20. Clear on this? The MIC is 20. You need only 20 to actually inhibit the organism. It's a very effective drug. So over a period of the entire dosage interval, it has been about 20. Right? It's been above MIC. Clear? Itna clear hai? This curve is only telling me where the antibiotic is going. That is why I need another curve that comes over here, which will give me the effect. So the effect is very good at this time. Effect is very good at this time. Though the concentration at this time is barely 20. Though the concentration at this time is barely 20. Though the concentration is barely 20 of the, see, this is how much the drug is inside the body, right? So it is 20, but the effect is maximum. It will be like that because suddenly the antibiotic is getting inside. The effect is maximum. Okay. Over a period of time, the effect is coming down. Effect is coming down. So at this point, your effect is kind of minimum. But the concentration of the drug is still higher, 40. The concentration in which the drug is there is still 40. The concentration here is 40. The effect has come down. Effect is still above the MIC, but the concentration here is 40. Okay, the drug goes in fast, but comes out slow. The drug goes in fast, but comes out slow. And hence, in order to find the interaction of the drug and the effect, we need to have both the curves, the pharmacokinetic as well as the pharmacodynamic curve. You understand? So you can't answer this. I can't with this curve. I can't figure out whether the drug is going to be effective or Rana can survive. I can't do that. This will only tell me absorption to distribution to elimination. This is all that is going to tell me. This curve. This is the pharmacokinetic curve. It will tell me only absorption to distribution to elimination. Absorption means it has been taken up. Distribution means where it is going. Elimination is how it is going out of the body. Right? And for those, the parameters that you require for pharmacokinetics is the volume of distribution, is the clearance, is the Cmax, is the C minimum, is the AUC 0 to 24. These are the parameters that come when you talk about pharmacokinetics. Right? These are the parameters that you think of, and these are the parameters that you look in the package insert for. And this is what will explain to you how to look after a drug. I will come to that now. Okay. So the most important of these is volume of distribution and clearance. Right? This is the actual curve. In this curve, I am breaking down this big curve into this small curve. I am putting the labels on it. So look at the labels here. So the onset of action, as I told you just now, what did I tell you? The onset of action starts right here. Because the MIC has gone above the MIC. The minimum effective concentration where the antibiotic starts working. So it's started over here. And then it goes up and reaches a Cmax, a maximum concentration that has reached. The time taken to do that is called as Tmax. The time taken to reach maximum concentration is called as Tmax. Okay. How much of the area is under the curve is the AUC. AUC. Okay. And then the action gets over here. and this part is the elimination phase. Beyond this part, the antibiotic is in subtherapeutic level. Clear? Clear on this? And when I talk about half-life, Cmax is here. How much time will it take to reach half of Cmax? Is your half-life. For example, if Cmax is here and half of Cmax is here, if half of Cmax is here, okay, if half of Cmax is here, say for example here, so I would plot this like this and plot this down. This will be my T half. 4 times my half-life is responsible for removing the whole drug from your body. Okay, 4 times of your half-life is to remove the entire drug from your body, and that becomes very important for you to understand. Why? Because tomorrow if you have a brain death patient, if you have a patient in brain death and you have a patient, you put the patient on say fentanyl or midazolam or Vecchione for that matter, you need to be certain that the whole drug is out of your body. Otherwise you cannot do a brain death determination test. The drug has to be out of your body. So what do you need to know? What is your T half? Because 4 times your T half means the drug is out of your body. So I'll go to my prescription, look my Vecchione, okay, T half is so and so. Okay, and then I'll calculate 4 times the T half and I'll say, oh, the drug is out of the body. I can do my brain death determination. Clear? Clear on this? Huh? Clear? Why importance of knowing these things? And it depends on the Cmax, Tmax, AUC to divide the antibiotics into various classes. It depends on all these. That's why you need to know these names, because that is how you determine the class of the antibiotic. So let's go to volume of distribution. So in a volume, this is where you see this. You see it in the package insert. You just open the package insert and you see VD written over there. Volume of distribution is very important because those that are less than 0.3, that is less than 0.3, they will stay in the extracellular fluid. That means it will be intravascular. That means it's a great drug when you're looking at bacteremia. It's a great drug when looking at bacteremia. A very poor drug if you have to go for tissue. Very poor drug if you're looking for tissue. Clear? Huh? The ones that are more than 1 liter per kilogram are great for tissues, but very poor for blood. Great for tissues, but very poor for blood, because volume of distribution means it is distributing quickly into the rest of the volume of the body. So more than 1 liter per kilogram. So if you see 20 liters, 90 liters, 80 liters, you see like that, no? Means what does that mean? ये bacteremia में काम में नहीं आने वाला है, इसको मत use करो. Don't use it for bacteremia. It's not going to work. You have to use it for tissues. Tigecycline is an example of that. Tigecycline is an example of that. Clear? Tigecycline is an example of that. It will get into the tissues quickly. That's why tigecycline is a great drug when it comes to skin and soft tissue infections. Are you understanding? Clear? Any doubts till now? Clear, no? Beta-lactams are great for ECF. Beta-lactams, meropenem, carbapenem. These are all great for that aminoglycosides. They stay inside. So tomorrow, if I want to give a combination of aminoglycosides with a drug for a patient who's severely septic, I'm not wrong. Why? Because it's got a volume of distribution that is quite low. It's not very high. Clear? Clear? How I'm looking at volume of distribution? How I'm using my pharmacokinetic data to understand which antibiotic to use? Clear? All right. Sorry. Total body water. Where is it in TBW?
Distributed TBW.
Volume of distribution.
Oh, okay. Into total distribution of total body volume. That gets into the entire total body water. Now, what I told you as a response curve, as I told you, there's a response curve, right? This response curve looks something like that. That is the exposure response curve. It actually looks like this. So, not by knowing just pharmacokinetic data, if I don't know what the effect is to the body, I can't really decide how and which antibiotic to give. Understanding? For example, I know the pharmacokinetics of say Anidula fungin. I know it very well. I know the pharmacokinetics of Anidula fungin very, very well. But what is its response in a urinary tract infection? It will not enter into the urine only. So there is no effect. So I can't couple my pharmacokinetic data and say, oh, it's a great drug, let me give it for urinary tract infection, because the effect in urinary tract infection is not there. That's why you need to create curves for effect. You need to create curve for effect, and the best combination of the pharmacokinetic and pharmacodynamic data is what you use to actually dose an antibiotic. So they create curves like this. Curves are created like this. And when you put both of these curves together, that is when you get the total PKPD. But for this curve, what are we concerned with? In this curve we are concerned with duration of time that the free drug concentration remains above the MIC. We get that. Duration of time that the free drug concentration remains above the MIC. Because I am looking at this part. This is the free drug. It is above the MIC. So how much is the MIC free drug above the MIC? I am getting this part. From my pharmaco dose response from this curve, I am getting this part. You understand? From this curve. I am also getting the ratio of Cmax to MIC. That means how much of the time is the drug at this level divided by the MIC. Cmax divided by MIC. And I am also getting the AUC in the last 24 hours. The area under the curve in the 24 hours. So these are the things that I am using from my pharmacodynamic curve. Pharmacokinetic curve I am using that. Clearance and all those things. And this is what I am using, this combination. Because I have added not only added my concentration and time, I have also added concentration and response and time. You understand? I have added my concentration and response together in one curve. And when you add concentration and response in one curve, you get curves like this. When I add both of them together, initially I had only concentration over time. I had response over time. Now what I am adding? Concentration and response together in one curve to get a curve like this. Okay, and what does this curve say? This is the AUC, area under the curve. Right? This is area under the curve. This is your MIC, which is the minimum inhibitory concentration. We'll come to that. Okay, MIC. What you're seeing here is the C minimum, that the minimum concentration of the antibiotic you are seeing. You are seeing C max. You'll see all this in the package insert. You must remember, you must see it in various studies. You'll see all these things. C max is a concept. It's very important because there are certain antibiotics that will completely depend on the concentration, effective concentration in the body. So one of the commonest examples of that is aminoglycosides. One of the common examples is aminoglycosides. It will actually depend how much your Cmax is to see the response. So tomorrow if you have aminoglycoside, the dose for amikacin is 15 to 20 milligram per kilogram. I can't give it 5 milligram TDS. You understand? Amikacin is 15 milligram per kilogram. So you might think, so 15 milligram in a 70 kilo individual, how much? 35, almost 1.2. Let's take it as 1 gram. 1 gram IBOD. So I cannot give it as 500 milligram BD. It's inferior. Why is it inferior now?
Concentrate. Cmax will not be attained.
Cmax will not be attained. You understand? Cmax. You need that Cmax to be maximum. Clear on that? So I can't use my aminoglycoside two times or 3 times. It has to be given single dose. Clear? How am I using my dose response as well as my pharmacokinetic curve? Huh? Clear on that? Then there is something called as a combination. A combination of concentration and time. Not only has the concentration to be good, but also the time should be high. Okay, so they are called as AUC divided by MIC. That's the criteria to figure out that. And usually quinolones come into that. Okay, that's why you may want to give ciprofloxacin BD. It's okay, give ciprofloxacin BD. Yeah, you may want to do that, right? And the third important category is time dependent. That means it is not determined as to how much you want to reach here. It only says that in my dosage interval, the antibiotic has to be higher than the MIC. So I can have my antibiotic like this. I can have it like this. Clear? I don't need it like this. Clear? I don't need it. I can have it like this. So in this category, what you must understand is dosage interval. Okay, you understand dosage interval. This means to say, if this is my dosage, I have 8 hourly dosage, 8 hours. I have 8 hours. These are two dosage intervals. 8, 8, 8. Okay. My curve here is like this. My curve here is again like this for the antibiotic. I have an MIC. MIC is going through, right? MIC is going through. Huh? At least for more than 40%. This is 10%, 20%, 30%, 40%, 50%, 60%, 80%, 100%. ये dosage का 100% हो गया. at least for 40% of my dose interval, my antibiotic should be above my MIC. Are you understanding? Clear on this? You understood this? At least for 40% of the dosage interval, my antibiotic has to be above my MIC. That's how I'm looking at it. Clear? That means it cannot be renally eliminated quickly. A drug you give it there, it comes out of the body, it doesn't make sense. And the criteria and the drug that actually does this on a regular basis is your beta-lactams. That is why we dose beta-lactams, BD, TDS, augmentin TDS, augmentin BD, ceftriaxone BD, we use cefazolin 3 times in a day. We do that, right? We do that because beta-lactams follow the time-dependent equations. Clear? Clear till now? So now what we have understood, we've understood what is Cmax, we've understood what is C minimum, we've understood half-life, we've understood peak, we've understood AUC by MIC, we've understood all of these things. There is another category of things called as, so we've understood all of these things, right? We've understood most of these things. So when I'm looking at elimination, PK, PK, I'm looking at all these equations. When I'm looking at pharmacodynamics, I'm looking at these things. But now we'll understand what this means. Frequency of time of the dosage interval when the concentration is more than the MIC. This is the meaning of FT more than MIC. You understand? Frequency of the time that it is 40% above the MIC in the dosage interval. You understand? When I'm saying Cmax to MIC means Cmax divided by MIC. That means our concentration dependent antibiotics. Okay. AUC 0 to 24 divided by MIC is what I'm talking of. The one that has both the characteristics to the quinolones. Right? So the best descriptors of clinical efficacy and bacterial kill for the concentration dependent activity would be these. Best descriptors. Now you understood this. Cmax by MIC. So tomorrow if somebody asks you aminoglycoside, the best description for its effective kill is Cmax by MIC. If someone asks about quinolone, it is AUC 24 hours by MIC. Okay, time dependent, it will be time over MIC of the dosage interval, we just now discussed. Time over MIC. I don't need to give 2 grams, 4 grams 3 times a day or 4 grams twice a day. It has to be 1 gram 3 times a day. It doesn't work otherwise. It's not going to work. Clear? Clear on this? And concentration dependent activity with time dependence, all the glycopeptides follow that. Okay, the glycopeptides, they follow that. Okay, AUC 24 divided by MIC. So this is how you divide the antibiotics per se. The antibiotics are divided this way. Okay, all the antibiotics are divided this way. Now, let us go back to our curve. And there is a very important concept that you should know, and in the future this might come in also. So when we described the curve, we said anything above this, the patient will respond because it's a MIC, minimum inhibitory concentration. Okay, that means to say it will inhibit the growth of the organisms. It will inhibit the growth of the organisms. However, there may be some amount of resistant organisms in that particular population. That will be somewhere here. In resistant populations, how much ever you give, how much ever antibiotic you give, this population of antibiotics, if there are organisms here, how much ever antibiotic you give, it will be resistant only. You give them 10 grams, give them 20 grams, do what you want to do, but it will remain resistant. Okay, so this is resistant part. Here there are some organisms that are above the MIC that are resistant. Okay, but they can be killed also, Aisa. Susceptible resistance types. So this is called as a mutant selection window. There is something called mutant. The mutants are lying here. The mutant selection window mein kya hone wala hai? Ki if your antibiotic is remained above this for a prolonged period of time, these mutations will occur over here, and this will now become here, get into this part. That means you have a group of organisms that are E. coli, say for example, of which some are resistant, some are intermediate, some are really susceptible. The susceptible are going to die here because they are in this part. But there will be a window when the antibiotic is in not that proportion. This is called a mutant selection window, where there is a possibility that in treatment you will get resistance. That means mutants are going to be formed. Okay, why you need to know that? Because you can actually predict resistance by actually looking at AUC 024 divided by mutant prevention concentration. This line is called as mutant prevention concentration. So if you want to know whether there is resistance going to occur to your antibiotic resistance, you need to know the MPC, mutant prevention concentration. It's a concept. It's a concept. So people abroad are trying to use this concept to figure out whether my antibiotic presently will be resistant or not. It's a concept. Clear? Alright, so that will basically be about resistance.
Some organisms are there always, which can mutate at higher concentration. So we can directly go for MPC, no? Why MIC?
That is the issue. Issue is that, issue is the very fact that you are balancing toxicity versus the effectivity. You go high, that means every person I can just give you high dose. It will cause toxicity. Our problem is not only this part of the story, it's the other part of the story. We have to balance. That's why you need to know the PK and the PD. You understand? Because a higher dose may not be effective because it may not be dependent on Cmax. It may be dependent on TMIC. And that's just a concept. Okay. So here you must understand these small points. MIC, you did this, Sachin. Can you tell me what MIC is?
Just minimum inhibited concentration.
So what does that mean?
So sir, so drug the antibiotic which we give. So it will the concentration of that antibiotic should be the minimum concentration of that antibiotic which inhibits the growth of that organism.
Exactly, which inhibits the growth of the organism. So this is done by various methods. What I have shown is broth microdilution. Okay, they put it in broth, and then they have looked at it. So there will be one place. This place you are taking it out. This much. This place is this much. That means it's not growing anymore. If it was growing fast, it's not growing anymore. So this is your MIC. For example, this is your MIC. Okay, but there is another factor called MBC. What is MBC?
It's killing
So if I take my organism from here and culture it, nothing will grow. It has killed it. Okay, so MIC and MBC are two different concepts. MIC is I have grown, and the dilution is reducing. I mean, I can see the dilution changing, the organism changing. I take out the culture from here, I subculture it. It is growing, but it is not growth. It's not multiplying. So that is inhibitory. That's how most antibiotics work. You give an antibiotic, it will inhibit the growth, and the body takes over and destroys the antibiotic. And that is the reason that in febrile neutropenia, we actually require bactericidal antibiotics, because you cannot have bacteriostatic. You need to be at that level. Body cannot respond. You understand? So in febrile neutropenia, the reason to give bactericidal antibiotic is because we can't wait for the body to respond. The body is not going to respond. We are waiting for the WBCs to go up. There is no WBC. Otherwise, generally in your and my body, I just need to inhibit. My body will take care of everything else. I don't need to kill. Are you understanding? I don't need to kill. Whereas MBC is actually bactericidal concentration. So now a very important concept. So let me give you an example and let me ask how you will take care of this. Okay, you have a sensitivity pattern. Okay, you have, let me take glycopeptides to be simple. Teicoplanin, your sensitivity is 0. You have got an MIC level that is actually said less than 0.25. And you have vancomycin which says less than 1. Both are actually sensitive. That's why you got MICs. You got MIC, that's why they are sensitive and they are saying. Which of these you choose? You have both. You have vancomycin and teicoplanin. Both are showing sensitive. Which of these antibiotics will I choose? Should I choose vancomycin or will I choose teicoplanin? How do you make that choice?
So less than 0.25 जिसका है.
No, it's not like that.
So in
What value? I've given you what you see in your chart. This is what is given. In your chart, you have just given this and बाजू में S लिखा रहता है. This is what is given in your chart, isn't it? In your chart, what is given? You have given a set of MICs are given, and उसमें S S S R R लिखा हुआ रहता है, right? This is exactly what I've given you. So how do you determine? And that's why you must understand the concept of minimum bactericidal concentration. Okay. So here, this concentration is actually called as break point. It's called as break point. That means how does this break point come? It doesn't come out of the thin air. They do loads and loads of tests from a laboratory from abroad called a CLSI or UCAST, and they come up with break points for that organism for that particular antibiotic. Okay, so all of these antibiotic with the organism, say E. coli or not, I can't put E. coli, Staph aureus, will have a break point. It depends on the break point, how far away from the break point you are to understand whether the antibiotic is better or not. समझ में आया? I'll explain this once more. Let's take the example of breakpoints fictitiously made. Okay, I'm making a breakpoint of say 0.1, and another antibiotic with a breakpoint of 0.05. Okay, I put the MIC here as 1, and I put the MIC here as 0.5. Or 0.5. Let me make this as 0.2. Okay, you might think that this is a better antibiotic. This is what it looks like. It looks like this, and it looks like this. You might think this is a better antibiotic, but this one is 10 times lower, whereas this one is only 5 times lower. Are you understanding? That means 10 times lower antibiotic. 10 times lower antibiotic. It needs such a small strength to actually kill. It needs such a small strength to kill. So my obvious choice for this antibiotic will be which one?
Upper one.
Upper one. No? You don't understand? Okay. What is bactericidal concentration? It is the one in which the organism is killed. I am giving you the breakpoint. That breakpoint is this 0.1. I am giving you the breakpoint. The breakpoint is 0.1. Matlab antibiotic X when I am using, I require only 0.1 to kill. I require 0.1 to kill. Clear? Clear on this? Antibiotic Y, I require somewhere around 0.2 to kill. For example, I require 0.2 to kill. Okay. Now, or let me put as 0.1 only. Let me put as 0.1 only. 0.1 to kill. Now your MIC that you found over here was less than 1. And MIC that I found was 0.5. So 1 to 0.1 पहुंचने के लिए कितना लगेगा हम लोगों को? 10 times. 10 times. That means 10 less than this concentration, 10 times less concentration than this may it actually kills. That means such a small dose it requires to kill. You understand? Whereas this is only 5 times what concentration we are seeing, MIC. So this means such a small concentration is killing, means this is more effective than this one. So that's what you see as therapeutic ratio, MBC divided by MIC. So MBC here, whatever it is, 0.1 over 1 versus 0.1 over 0.5.
How will you get MBC?
Exactly. How do you get the MBC? That is the reason you need the MBC, and for the MBC there is a CLSI guideline. Just go to the CLSI, open up the chapter, look at MBC. The numbers are given and it changes every year. You understand? So if you want to, so if you have a difficult to treat organism or a choice that you want to make between two antibiotics which have almost the same pharmacokinetics, this is only when the pharmacokinetics are the same, right? So if the pharmacokinetics is the same and I want to choose an antibiotic and I have the MIC patterns, I need the breakpoints. So when I get the breakpoints, I can now do the therapeutic ratio, and the higher the therapeutic ratio, higher the effect. So understood the concept? Did you understand the concept? Understand? So if you open up CLSI guidelines, you will find breakpoints. Every organism does not have breakpoints. That is also there. Okay. So you have to see for the breakpoint whether this is there or not. It is just one chart. You can just download it, you get the chart. So ideally what
is a very big.
Yeah, it's a very big chart. But you need to, if for the difficult organism that you have a difficulty in understanding whether what to use, like for example here I give you an example, you look at the MBC and come to your therapeutic ratio. Clear? Clear on this? Clear? So when an ID physician is consulted for a difficult to treat organism, they start thinking like this. What is the MBC? What is the therapeutic ratio? You know? Clear on this concept?
So ideally in all, like we should have the breakpoints.
We should have the breakpoints.
So
Yeah, we should have the breakpoints. So ideally we want so if you see certain laboratories like Hindujam, they give you breakpoints. You know, if you ask for the breakpoints, they'll give it to you. If you call up to me and tell I want the breakpoint, they'll give it to you. They will have it. So when you call a microbiologist and ask her, इसमें से कौन सा देने का दोनों sensitive है, they will actually look at that and tell you, use this. Because they have it in front of them. The MPC is right in front of them. You understand? Because that thing will come to your mind only when everything else is the same. Whatever distribution हो गया, pharmacokinetics हो गया, everything else is the same. Clearance हो गया, same. Elimination same हो गया. Then you come to that. Okay, now tell me what to use. That's why you need to know the rest also properly. You understand? To come and understand this thing. So how to use this stuff? Now let's go to a practical example. Okay, how to use this stuff? All right. PKPD. So once more, volume of distribution. Which are the drugs that have very high volume of distribution? You must remember one of each. Okay, one you must remember. So the ones that have very low, very high volume of distribution will be the one that get into the tissue. So you must remember colistin, tigecycline. Remember that. Clarithromycin, azithromycin, macrolides, fantastic drugs into the tissue. That's why we give it for pneumonia. It just gets into the tissue. Fantastic drugs. I don't require anything bigger and different. Fantastic drug. Right? When you say anti-stain, the extracellular fluid, that is the one that remains inside the blood, is aminoglycosides. One of the classical examples. Beta-lactams also along with these. Okay, and drug that is total body water, clindamycin. That's why we use it for skin and soft tissue infections. It gets into the tissue very quickly. Maximally into the tissues. You can't use clindamycin for a blood-borne infection. It's wrong. It's completely wrong. If you use clindamycin for a blood-borne infection, it's completely wrong. I won't use this. Clear? Clear? So that's PKPD about volume distribution. Now when you look at protein binding, this is high protein binding. That's what I told you. Ertapenem, I will never use when there is going to be a severe sepsis, septic shock, because what is going to happen? It will get bound to the proteins. No free drug is there. No unbound drug is there for action. You understand? Classical examples are ertapenem for this. Classically. Then you have something called as augmented renal clearance. Okay. Every drug in our body will have augmented renal clearance if it is going on from the kidney. Why? Because what happens in our body, something very funny. What happens is, the moment there is sepsis and septic shock, what is the fight and flight response for you? If today you are standing up and trying to take a talk, first thing what you do, go to the toilet, you pass out urine. Sussu aata hai na? It's a fight and flight response. So sepsis forms augmented renal clearance. It actually increases the amount of the throwing out of the drug. So you must remember this as an intensive care doctor, that most of your drugs have to be dosed on a higher ranges rather than the lower ranges, because you have this something called as augmented renal clearance. The younger patients have got higher augmented clearance than the older patients. So remember this, younger the patient, higher the drug. Younger the patient, higher the drug. Remember this, okay? Younger the patient, higher the amount of blood, lower the amount of blood pressure, higher the amount of augmented. Both ways, okay? All are very important. Okay? Physicochemical properties. Another very important parameter that we look into when we are actually dosing our drugs, which is either hydrophilic or lipophilic. The lipophilic drugs are the ones that actually get into the tissues. They are lipophilic, they are fats, they get into the tigecycline, macrolides, monofluorophenols. They will get into the tissue. That's why for an osteomyelitis, it is making sense to start the patient on ciprofloxacin. For an osteomyelitis, for a ear infection or CSOM, I would probably use ciprofloxacin, because the drug penetrates into the various tissues very quickly. I won't go and use a Keftam there. Doesn't make sense only. I would not go and use Septum there. Somebody calls me and says, give me, I have a middle ear infection and it is probably gone into the stirrups and whatever is called as inside. I would not give him Septum just because I know Septum is family member BD. I would still give him ciprofloxacin because it is more lipophilic. It will get into the tissues. Are you understanding? Clear on this? That's how we discuss when you're looking. So we have so many things that we look at. We have to look at volume of distribution. We have to look at PK. First you have to start with PKPD. Then you have to look at volume of distribution. Then you look at clearance. Then protein binding. And then you look at physicochemical properties to actually arrive on a certain antibiotic. So it's not easy. It's not easy. So whatever you see as guidelines have taken all of these together and then given you an answer. So the recipe that they have created for you is made it simple. But the recipe per se is difficult. You know, they have given you something in your hand. Remember that, that's why it's very easy to take up a guideline and read it. It's easier. So what I'm going to do is, I'm going to show you some of these examples. Okay, hydrophilic.
So, about augmented renal clearance, they said kidney should be normal.
Yeah, kidney. But most of the patients who have sepsis, at that particular moment, irrespective of the kidney functions, they have augmented renal clearance. You know, it's like that. It's okay. So let us. So when we look at those, so most of these time-dependent antibiotics, most of the time-dependent beta-lactams will be hydrophilic. I'm now correlating what we had discussed earlier, concentration dependent, time dependent and AUC. So most of the time dependent antibiotics will actually have will be actually staying in the extracellular compartment, will have a chance of being hydrophilic and will be high to moderate protein bound. Okay, more that is, and importantly, that is why we discussed about that dosage interval. You remember I told dosage interval? Their dosage interval. So because they are a combination of these problematic situations, they are problematic. No, अगर तुम बोल रहे कि वो is staying in the extracellular fluid, then how will you get into the tissues? It's problematic. So I need to optimize them. And that is why you need to know the frequency of time interval in which it is above 40%. Right? So most of them need to be kept between 40 to 70%. How do I know it's 40 or it is 70? You are understanding this 40 to 70 concept, right? I said dosage interval. Remember I said, I talked about dosage interval. And I said 8 hours and 8 hours. And I said at least for 40% of the time, more than 40% of the time, I need the drug to be above the MIC. I explained that. Then the antibiotic will work well. Huh? But unfortunately, when you say time dependent activity, it is a range from 40 to 70. That means there are certain drugs that will keep at 40 and a certain drugs that will keep at 70. Which will be a big difference between the dosing of the antibiotic. You understand it? So, it is more than 50% for piperacillin tazobactam. Remember this. Okay, it is very much higher for ceftazidime and cefepime. That's why some days ago I was saying it's for 2 grams. You remember? I was talking to you, it's better to give cefepime 2 grams rather than 1 gram. Remember I was talking to you about some who I was, I don't know when I was talking about the cefepime, I was talking to you about that. Huh? That's why, you know, ceftazidime we want to dose as 2 grams. That's why avibactam, ceftazidime, avibactam that we are using has 2 grams of ceftazidime. Because you want to keep it 70% times. Okay, and carbapenems are only 40%. I don't require it to be higher than that. You understand? So I don't need to give 3 grams of Darapam. 1 gram TDS is enough. Huh? You understand? Huh? Clear on that? So that's why these drugs, you want to use an initial loading dose with prolonged infusion. Now you understood why prolonged infusion. You understand? Huh? So if I want to give prolonged infusion, and I now dose my piperacillin tazobactam as 2.25 grams 3 times a day, what am I worried about? I am worried about the fact that I might be in the mutant selection window. That is my worry. Are you understanding? That is the side effect. That is the problem of extended dose interval. You remember I talked to you about mutant selection window? So you might be in that window. You must be careful to find out whether the patient is clinically improving or not. If you are on an extended infusion and the patient is not improving, most probably selected the mutant. Okay, so it's very important to understand this. So highest possible dose you should use for critically ill patients. Highest possible dose. That's what we think. We want to give the highest possible dose when you look at time-dependent antibiotics. I don't want to give the lower dose. I don't want to give 4.5 3 times a day. I want to give 4.5 4 times a day if it's piperacillin tazobactam. Are you understanding? I don't want to give 3 times a day because I want that time above the MIC. Right? So BL, BLI, carbapenems do well with prolonged infusions. That's why they do well with prolonged infusions. That's why if you want to give ceftazidime, avibactam, I want to give it over 3 hours. If I want to give meropenem, I want to give it over 3 hours. It makes sense. It makes sense. You understand? Huh? When MIC is more than 4, it's important to keep the MIC 60 to 70%. So if the MIC you see is 4, more than 4, irrespective of what the antibiotic is, keep it above 60 to 70%. That's how I'm going to use the MIC now. So if I see the MIC is more than 4, irrespective of what is happening, any BL, BLI or beta-lactam, I want to keep high concentration inside the blood, more than 60 to 70% of the time, so I will give high concentration. Clear? Huh? Hence high dose prolonged infusion is just not prolonged infusion, it's high dose prolonged infusion. Clear?
Sir, but prolonged infusions we have not seen in many.
3 hours. When you say ceftazidime, we have to be writing over the 3 hours. You understand? When we are putting, see, if you have a patient that is easy to treat, it's okay. But if you have a patient that is difficult to treat, see, we say, I give prolonged, I want to give prolonged. You understand? So if I have a patient that, for example, whichever patient is giving ceftazidime, we have to give around 3 hours. You do that. Okay. So no post-antibiotic effect. What is the post-antibiotic effect? So we would say Cmax over MIC, antibiotic aminoglycan given once a day. What happens to the rest of the day? When it is going down. When it is going down the rest of the day, there is still a post-antibiotic effect even though the antibiotic aminoglycoside is below the MIC. That's called post-antibiotic effect. Unfortunately, beta-lactams don't have any post-antibiotic effect. And that is the reason you want to give it 3 times to 4 times or whatever. More the better. Ampicillin is given 6 times. Ampicillin is given 6 times. You understand? It's given 6 times in a day. Fluoxetine is given 6 times in a day. They are beta-lactam antibiotics. You understand? Clear? Clear on this? Huh? So, so this is how the independent will work. Huh? this is how the extended duration will work. So obviously extended when I give, at least in the dosage interval, 40% of the time it is, more than 40% of the time it is above. Whereas if I give just intermittent, it will go up and come down, it is not 40% of the dosage, it is less than 30%. You understand? So it's a problem when you're looking at something like that. Okay, so it's very important to attention to penetration when you're looking at PLI, because what we just now discussed is the fact that that it may stay, it may distribute not very well, at the same time high to moderate protein binding. So you have to understand penetration. For example, if you have a patient with meningitis, many of the antibiotics will not even enter into the brain. Many of these lactam antibiotics may not enter into the brain. You must be careful. Okay, so penetration is very, very important. And so let us take the example. Okay, now I'm going to put all of these things in a very complex manner and try to simplify it. I'm going to put volume distribution, clearance, peak level, everything, and try to make you understand with an example. It's a beautiful example. Okay, so I have a patient who is having ventilator-associated pneumonia, and it is showing pseudomonas. Okay, I have ceftazidime. The MIC is 8. Okay, the MIC of this organism is 8. All right. I want to use all my parameters together, and I have to decide which of this I want to use. Ceftazidime, avibactam, cefepime, amikacin, or gentamicin. So, what would be your choice, Sachin? I have only one antibiotic to use. Can't use all 4. So that's why you must understand the whole concept. Let me come to the concept. Okay. So let us, obviously you cannot use amikacin and gentamicin because no penetration. It is not entering into that side. Epithelial lining fluid is not even getting touched with amikacin. Okay, so I have already looked at penetration. I have looked at penetration. My penetration is in my mind. So in my first thing is it going to penetrate? No, it's not. It's not going to penetrate. Okay, it's not going to penetrate. Now I am left with the sensitive situation where ceftazidime and cefepime is there. It was sensitive amikacin also, but I can't use amikacin. I can't use gentamicin. Both being that remains in the intracellular in the vasculature, does not enter into the lungs. At the same time, gets inactivated in the lungs. So very different. Not inactivated, doesn't penetrate the lungs as well. So amikacin and gentamicin is effectively out. I will not use amikacin. I will not use gentamicin for my back. If at all I want to use it, I may want to use it through the inhale route, because that is the only way it can get inside, and there are controversies about it. Okay, because it is now going to penetrate, I am trying to put it from inside, from the inhale route. Clear on this? Clear till now? Now the question that comes is, what am I going to use? Cefepime or ceftazidime? That's why you need to know the package insert. Now I will go to the package insert and understand how this works. Okay, so either ceftazidime. Remember this: the penetration into the lung is 25% for ceftazidime. Penetration into the lung or distribution in the lung is 100% for cefepime. Okay, but I have an MIC here. I have put all of these things together. So in the lung, ceftazidime is 25%. It is there. If you look at the packages, it will be written on that 25%. Cefepime is 100%. Right? Both of my drugs are beta lactam. What are they going to follow? They are going to follow all those where I need the time above my MIC. I need to give it 3 times in a day. It has to be above the MIC for maximum amount of time. Right? It does not have a post antibiotic effect. It's not very, it's moderately protein bound. So there are all these things coming into my mind. So I'm going ahead and I'm looking at the peak serum levels because I need to know the peak serum levels. So what happens to my peak serum levels is the moment I give 1 gram of ceftazidime, the peak serum levels go to 69 grams. Okay, peak serum levels. Alright, just remember this. Okay, this is what happens when you give the Cmax. You know Cmax, you want the Cmax. So we have now put Cmax into the equation here. Cmax 2 grams 164. This is the usual dose. Okay, now percentage protein binding. Let's put that inside. The percentage protein binding of ceftazidime is less than 10%, and the percentage protein binding of cefepime is 20%. Moderately protein bound. Clear? You understood this much? This I got from the package insert, this I got from the package insert, this I got from the package insert. Now see what I'm going to do. Okay, the half-life is what we discussed. So Cmax coming down is 2 hours, right? So it's 2 hours over here. And both is 2 hours. Now, that means if I go to give 2 grams of this particular drug, ceftazidime, I'm going to give high dose. So I'm going to give 2 grams of ceftazidime, which is the usual 2 gram TDS. That's what evic as we just now discussed. Ceftazidime vacuum is 2 grams. So I'm giving 2 grams. So what is the peak level? 138. 69 plus 69. 138. Clear? Huh? Now we are removing 10%. Only 10% is going to be active. Because 10%, only 10% has to be inactive because it is bound. It is bound. So I am going to remove 10% from here. That means 138 minus 13.8 is 124 milligram per liter. Okay, this is what you are going to get. Okay. Now, what I am going to do over here, I am going to take only 25% penetration into the lung. How much? So out of this 124 milligram per liter, it has gone into the body and created 124. But how much is going to go to the lung? Only 25%. So let's put 25%, means 32 milligram per liter. Right? 25% of that is going to go into the lung. 32 milligram per liter. Right? And the half-life is for 2 hours. So I'm going to give 2 grams 3 times in a day. Is what I'm thinking. So let me now look at 2 half-lives for it to get out of the body. Because I want when it comes down the MIC also. So 4 half-lives, say 2 half-lives I'm looking at, say mean after 4 hours will be 8 milligram per liter, almost half ho jayega, more than less than half. Less than half. So to reach 8 milligram, which is my MIC, within 4 hours it will be 8 milligrams. Clear? Within 4 hours of my dose of high dose ceftazidime, it will reach MIC of 8 milligrams. Within 4 hours. So if I give my drug 2 gram BD, is it justice? Not at all. Not at all. Why?
So, like it will remain below the MIC curve for long.
More than 60-70% of the times. More than 60-70% of the times. Right? And we discussed that if the MICs are more than 4, we want to keep it at least 70-80% of the times higher. We discussed that, right?
Yes.
We discussed in beta-lactam that if it is more than 4 MIC, I want my drug to be at least 70-80% of the times. So when I put this into my equation, it goes down to 8 milligram per liter within not even 40%. You know, not even 40%. It looks not even 40%, isn't it? Huh? It's not even 40%. The time of our MIC is maybe approximately 50%. What do I want? 70%. Huh? So ceftazidime thus remains above the MIC in 50% of the dosage interval. You understood this much? How I looked at all these things? How I utilized it? Sub decay, I have come to that equation that says 50% of the dose. I have used my pharmacokinetics, I have used my pharmacodynamics, and I have used whatever equations I have. This is given to me, and I have told you what's happening. Right? Now this is about ceftazidime. Now let's go to cefepime. Okay, let's go to cefepime. Cefepime is 2 grams, 164. This is the usual dose I'm going to use. 2 grams is 164 milligram per liter. Now let us see if I were to take it 20% protein bound. That means I have to minus 20 from this. Right? So I'm going to minus 20%, which is 32.8, which is 130 milligrams. Okay, approximately 130 milligrams is what I'm getting. Right? Now 100% of that gets into the lungs. 100%. So I am saying the whole lung is 130 milligram per liter. Right? Now what I'm going to do? I am going to look at my half-life of 2 hours. So how much time it will take to reach 8 milligrams is the question. How much time will it take to reach 8 milligrams? That is my question. Okay, because once it reaches 8 means it's below the MIC. So it is going to take 8 hours. If I divide this again and again, it is going to take 8 hours to reach 8 milligram per liter. That means 4 half-lives. That means how much of the dosage interval is above 8 milligram per liter? My dosage interval is 18 hours. 100%. 100% over dosage interval. You understanding? You are understanding? So 100% of the times, when it was 130 milligram per liter, it took me 4 half-lives to attain 8 milligram per liter. 4 half-lives is equal to 8 hours. 8 hours. Because the half-life is 2 hours. Okay, 8 hours. That means if my dosage interval is 2, 100% of the times, my cefepime tazobactam is over the MIC. You understand that? So I have used my pharmacokinetics, my pharmacodynamics, and I have come to an answer as to what I should be using. Whether I should be using ceftazidime or whether I am using cefepime. So I have just given you an example of how I would use these for my daily practice. I don't need to do that now because I have done this so many times, I know what to do. But if somebody asks you tomorrow, एक घोड़ा है तेरे सामने, veterinary doctor बन गया तू, हाँ, उसमें you have to think, no. अभी तुम्हारा, it's the most difficult medicine, most difficult drug delivery is in veterinary medicine. The most difficult drug delivery, because fortunately for us, everybody is this size. But they will be dealing with pigeons and horses. You know, so when they deal with pigeons and horses, they have a different volume of distribution, they have a different peak effect, they have a different Cmax. So for them, a drug calculation becomes unbelievably difficult. A pigeon will have a different versus a horse will have a different. Even two horses will be different because the horses, one is bony and one is big. You understand? So when you go to a veterinary equation and veterinary website and try to figure out PK/PD, you just realize, wow, my God, this is crazy. You understand? So fortunately for India, for our human race, we are of one type. Okay, and most of the time, what has happened is most of these things are already mentioned in your paper. But this is how they are mentioning it in the paper. How is it coming into the guideline? How is it coming into this? By doing something like this. That's how PK/PD is used to actually figure out what should be the drug dose. Clear? Clear on that? Huh? Hydrophilic antibiotics that stay, concentration dependent activity. So this is the hydrophilic variety, and hence use the higher doses to reduce nephrotoxicity and increase kill. This is the aminoglycosides, which are concentration dependent. Peak over MIC should reach 8 to 10 times the MIC. I will use the same thing for all my aminoglycosides. I want to give it as high as possible above the MIC, the peak levels. That's why I want to give it once in a day. And post-antibiotic effect allows once a day dose. That's why even if it goes down below the MIC, I'm okay with it. Hence use higher doses once a day to reduce nephrotoxin and increase kill. That's why we give aminoglycoside once in a day. It increases kill, reduces nephrotoxicity, and some MIC drug levels can be tolerated, and less fraction dosing can be favored. You don't need to give 3 times in a day. That's why we favor in concentration dependent activity of enzymes to antibiotics to be given once in the day. Clear? Clear? Any doubts? Concentration dependent activity. So peak MIC 8 over 10. So applying volume of distribution. I know this is there. Okay, let me apply this to aminoglycosides. Okay, the same thing I'm going to apply to aminoglycosides. Let's say, okay. So gentamicin. Okay, gentamicin. What is the concentration? Dose divided by volume of distribution. This is the concentration. Dose divided by volume of distribution. So I'm going to give 2 milligram per kilogram of gentamicin. Usually the dose is 6 to 8. So if I'm going to give 2 milligrams, if I make it 3 times in a day, for example, if I make gentamicin 3 times in a day, okay, gentamicin, I'm not going to give it as 5 to 7, I'm going to give it 3 times in a day. Okay, so 2 grams of gentamicin into 70 divided by 0.3 liters, because that's the volume of distribution. We just now saw that 0.3. We saw the volume distribution 0.3, right? We saw that. So volume distribution is 0.3. I got it from the chart over there. It comes 6.7. 6.7. MIC was 4 for this particular organism. 6.74. It is 1.7. Clear? This is my Cmax. And what did we say just before this? What should be a Cmax? 8 to 10 times the MIC for our aminoglycosides. 8 to 10 times over MIC. So, is this 8 to 10 times over MIC? No, na? It's only 1.7. It should have been 8. Not in 8. 32 or something it should have been. Isn't it? So now, let's see amikacin. Okay, the same thing. Dose 7.5 into 70, that's a higher dose, divided by 0.3. Concentration is 25 milligram per liter, that's what you're getting. Cmax over MIC is 25 divided by 4, 6.25, closer to 8. Closer to 8. You understand? Meanwhile, if I convert this amikacin to 15 milligram per kilogram, it will be most closest to 8. You understand? It will be most closest to it. You understand what I'm saying? If in this category of cases, MIC is not met. 8 to 12 times the MIC, it is not met. Right? It is not met because we had 8 to 12 times the MIC we needed. Okay. Now, if I increase this gentamicin to its actual dose, 7 milligram per kilogram. I said 5 to 7 is what you normally want to give for gentamicin. I made it 7. Whenever I reach 5.8, still closer to 8. And in the amikacin I did, I reached
12.8.
So now, what is the dose that you will use? If it is gentamicin or amikacin, a higher dose, because it still reaches closer to the MIC, at least 8 times the MIC. So I have used again my pharmacokinetic and pharmacodynamic data to understand why I should be giving high dose once a day aminoglycosides and what they actually give in that. I'm only looking at this formula and doing it. You understand? Clear on this? Clear? Okay, so the goal is met. That's how, so this is an example of how aminoglycoside we are using, right? Now, hydrophilic antibiotics are the ones that are clindamycin, linezolid and things like that. Here, it's important to actually maintain AUC more than 400. Now, let me tell you one thing. I don't think I have an equation for this. If it's serious, it needs to be 400 to 600. Means the highest toxic dose of glycopeptide. Means vancomycin will be dosed at 30 milligram per kilogram. Then only you will reach such high doses. So if you want to use vancomycin in serious infections, you have to dose it at very, very high amounts. That's what this means to say. In serious infections, this AUC, because I don't think I have it. I don't have it. So the loading dose has to be very high, 25 to 30 milligram per kilogram. Okay, and then just send the column sometime. Okay, and then 15-20 every 8 to 10 hours. Serious infection require very high doses, and since you are giving very high doses, there is going to be serious nephrotoxicity, and that's why I'm going to give therapeutic drug monitoring. It's very, very important in these cases because I may lead to toxicity at that doses to maintain 400 to 600. Continuous infections are also acceptable because it's AUC 24 hours. So that is also are acceptable dosing strategies in these cases, and they have been linked to lower toxicities. Clear? So when it comes to concentration, when it comes to this time-dependent concentration activity, which is characteristic of glycopeptides, I want to give the highest dose. I want to probably give it as extended infusions, and it's important that I monitor therapeutic drug monitoring because the toxicity levels are very, very high. Clear? Okay. All right. So now what we did, we've understood volume distribution, we've understood metabolism elimination, we've understood physicochemical properties, we've understood. So metabolism, I didn't really touch upon this. So those antibiotics, if you have a UTI, I want those antibiotics that are excreted in the kidney. I can't give metabolism that's in the liver. So it has to be excreted in the kidney. So aminoglycosides, they are actively secreted into the kidneys. I'll use that. Are you understanding? I want those antibiotics. I want to, so there's a small difference between that also. It is not so simple. For example, if you have a patient on pyelonephritis, I don't want it just to be excreted in the kidneys. I also want it to go into the tissue. If I have a cystitis, I just want it to be excreted in the kidneys. You understand? So if I have a cystitis, I can give a nitrofurantoin. I can give fosfomycin oral. It will just be in the kidney, but not in the kidney. It will just be outside cystitis, just outside. वहाँ से निकल जाएगा वो. ठीक है? But if I have pyelonephritis, the same fosfomycin I can't use. It will not get into the kidney. Are you understanding? Clear on this? That's how you are thinking. Okay. So metabolic elimination. So aminoglycosides are excreted in the kidney. That's why I prefer to give aminoglycoside in UTI. They are concentrated in the kidneys. You know, they increased secretion to the kidneys. Okay. The augmented clinical, we talked about it. We talked about MIC and susceptibilities and MBCs and kill ratios. We talked about physicochemical properties, hydrophilic and lipophilic and things like that. We talked about volume distribution very clearly, and we explained about protein binding. So this is all about PKPD. So now when you go back to Rana, okay, we go to Rana. She received a standard dose. Definitely, we will not use a standard dose now. Looking at all these things, she is hypotensive, she has cellulitis, she has pyelonephritis. Would I use the standard dose? Why would you not use meropenem 500 milligrams? A, because it is a beta-lactam antibiotic. And so, what are the characteristics that I need to follow when I look at a beta-lactam antibiotic, Elizabeth?
If it is MIC more than 4, I'll keep it as a prolonged infusion.
Number one, and I need the highest dose possible. This is not the highest dose possible. I can't give the highest, and I also need to give a what? A loading dose. Because I need to achieve that. So I want to give a loading dose here. So there are 3 mistakes in this. They have not given a loading dose. They haven't given the highest dose possible, and possibly I would use an extended dosage interval. All 3 things, right? What about TSI given here? So here again, this has got a it's got a very high volume of distribution. Okay, this patient who is hypotensive, who has got shock and all happening, all these things happening, is going to be probably bacteremic, because severity of infection is, when he started lecture I said severity of infection is very important for me, probably going to be bacteremic. If it's going to be bacteremic, TSI may not be a great choice here. It may not be a great choice. And even if I want to give tigecycline in this case, I will want to give 100 milligrams twice a day because in bacteremia that is the only dose I can give. So maybe I'll have to increase the dose to 100 milligrams twice a day. Right? So you cannot give standard doses, number one. In the ICU, we can't use standard doses when it comes to ICU care. These are only for healthy individuals. So application of a standard antibiotic dose is therefore grossly flawed. You can't use the package inserts. It's wrong to use the package inserts because they are basically done on healthy volunteers. Okay, and that's why when you have difficult to treat organisms, you should be able to use PKPD. Without PKPD, understanding of the correct understanding of PKPD, you can't really take care of patients in the intensive care unit, and that is the reason PKPD becomes very important. Right? Thank you, Trizat.